Dr. Van Meter, if that's all right with you, you can begin your testimony.
I'm Quentin Van Meter. I'm a pediatric endocrinologist in private practice in Atlanta, Georgia. I am board certified in pediatrics and also board certified in the subspecialty of pediatric endocrinology. I received my medical degree at the Medical College of Virginia in Richmond and proceeded on to a Navy career of 20 years, during which time I completed my internship and residency at the Oakland Naval Hospital affiliated program of University of California, San Francisco. And then I practiced as a pediatrician in the Navy for several years, and then went to my fellowship at Johns Hopkins, sponsored by the Navy as well, and then decided to stay in for a 20-year career because of the teaching opportunities that I had as a staff pediatric endocrinologist in San Diego Naval Hospital, and then as a department chairman and a residency program chairman in pediatrics at the Naval Hospital in Oakland. During all those years in the Navy, I had affiliations with my partner civilian teaching institutions in the community in San Diego and in San Francisco, briefly in New Orleans while I was stationed there as well. And I've maintained those academic positions as clinical adjunct faculty, and today I'm on the faculty of Emory University School of Medicine and Morehouse College in Atlanta, Georgia. So that's my background. How I got into the issue of transgender is basically from my fellowship days back in the late 1970s. On the faculty at Johns Hopkins was a clinical psychologist of note, Dr. John Money, and he developed what was called the psychohormonal clinic. And that clinic was of interest to him because we had a number of patients, infants and toddlers, who had disorders of sexual differentiation or who had precocious puberty. And his idea was to evaluate the psychological basis of their adaptations to these issues and kind of come up with a theory, if you will, that he promoted about what happens to the gender of this child. He actually coined the term gender identity. Gender before that, if you look back in medical textbooks, didn't exist as a medical term, but was a linguistic term. It referred to the nouns and pronouns in languages, in various languages around the world. So he looked at that, and his personal opinion was that gender identity essentially is one's internal sexed self, how they view themselves in the world. And he thought that by age 18 to 2 years that the gender identity became a bit more concrete, and that it was, again, an interaction of the physical findings of the patient and their surroundings that brought that to fruition. So his problem in terms of science was that he was not a man of science. He was a man of, I have an idea. I really firmly believe that this is a concept, and what I would like to do is to treat patients with my concepts and see what happens to them. These were before the days of committees that protected subhuman subjects from experimentation. And so he did his theories. He applied them to infants and toddlers in terms of gender assignment based on ambiguity of the genitalia at birth. And he processed a number of patients through, including patients with precocious puberty, and came up with outcomes that, in retrospect, were somewhat disastrous, including a very well-known case of one of twin boys who was reassigned a gender of female at birth after accidental amputation of the penis during a circumcision. And that child grew up believing as a female. Was under the guidance of Dr. Money, was instructed to play sexually with the anatomy of the brother, the other twin, throughout young childhood, and then subsequently in adolescence, this child was morbidly depressed and anxious, and he was told that indeed he was not a girl but was born a boy, and that at that point in time he requested to have surgical reconstruction of what was left of his phallic stump, and so he became, again, in his young adolescence, identified as a male, subsequently married, and subsequently took his own life. And this one particular case sort of closed the door on Dr. Money's career at Johns Hopkins. It occurred over the time that he was there. The chairman of the psychiatry department at Johns Hopkins, a very notable, worldwide, well-published physician who writes extensively on human sexuality, Dr. Paul McHugh shut down the psychohormonal group because of that particular issue and others that had surfaced by that time. Simultaneously, as a pediatric endocrinologist, we were charged with looking after the adult, what were then called transsexual patients, that Dr. Money had worked through his protocol with social affirmation, medical affirmation, and surgical manipulation. And we were asked to take care of those patients because the adult endocrine division refused to do so. So we had exposure to those patients and their social circumstances. And that, again, was buried and put away as an experiment that failed. And that was the end of that as far as we knew it from the endocrine standpoint. So I finished my fellowship and had my naval career, and moved to Atlanta, Georgia in 1991. And 2 years later, I was approached by a family who had just moved to the area, a military family from Southern California. And they presented to me their son, who was cross-dressing and identifying as a female, who had obviously had gender dysphoria, what is now described as gender dysphoria. They came to me to seek hormonal treatment, and again in 1993. Nowhere could I find among my endocrine colleagues and my mentors across the country any advice on what to do with hormonal treatment. It was unheard of. It had not happened, as far as we knew, in children. And I was advised to get an attorney to write a very specific kind of a protocol of informed consent and assent on the part of the patient. And I was advised that perhaps I should start this child on estrogen therapy, which I did. The follow-up for this patient was lost because the family moved again 6 months after I began therapy. And that in 1993 was the only case I knew of, and none of my endocrine colleagues in and out of academia and clinical practice had ever experienced someone coming to them and asking for information on what to do. So to put that in the scope of things, that's where we were back then. And we fast forward from 1993 to the year 2006, when Dr. Norman Spack from Boston came back from the Netherlands, where he had sort of been mentored in their Dutch protocol, and opened up what was then the first transgender clinic in the United States. So if you think about the time scale of where these kids were, wondering where were they in the woodwork, what was happening to them, it was a landscape, an empty landscape at that point in time. Dr. Spack's clinic was the first, and within 2 years, he was on the committee of the Endocrine Society. The Endocrine Society is a professional group to which I belong, among other professional groups. The Endocrine Society had a committee that they put together. It was a special interest group, so-called. Endocrine Society is a national organization with some international ties. Membership estimated to be somewhere around 20,000 members. It is predominantly an academic group. It's predominantly university-based and adult-oriented. There's not a pediatric subdivision of the Endocrine Society, but most of us in pediatric endocrinology belong to that organization because of the continuing medical education opportunities and mentoring with our colleagues on the adult side. The Endocrine Society group, there were 9 of them initially. On that group were only people who were WPATH members of the committee, half of them from Europe, half of them from the United States. Of the endocrinologists on the board of that 9-member committee, there were only 4 endocrinologists. The rest were mental health providers, a general pediatrician from the Netherlands, mental health folks, and adult endocrine people. These guidelines were made specifically for the treatment of transgendered kids, specifically guidelines what to do with children. And only a fraction of the committee that designed these guidelines were actually pediatric endocrinologists who would be knowing the ins and outs of what would happen to with medication and subsequent surgical recommendations. So this committee convened. It put together its recommendations. There were 23 of them, and they are published in the Journal of Clinical Endocrinology and Metabolism. They rate these guidelines from 1 circle to 4 circles in terms of scientific basis. 4 circles being very strong scientific basis, 1 circle being none or very limited, and then graded in between. 2 is a little bit of science but not much. 3 is moderate amount of science, and 4 So each of these recommendations had what's called the grade system attached to them. Only 3 of those 23 recommendations had any moderate scientific basis. And those were, we don't know what to do about cross-sex hormones and the safety of them. That needs to be studied. We don't know about blocking puberty. That needs to be studied. Those recommendations had the scientific basis behind them, saying there is no science. We know what's in literature, and it's not there. It needs to be, and that should be looked into. The remaining 19 of the guidelines, excuse me, 22 guidelines in the first, were half no science whatsoever and half potentially a little bit of science. Not only did they grade those that way openly, then they put their recommendations of a strong recommendation or a mild recommendation to put to label each of these recommendations. For reasons that they openly admit and publish in the guidelines, they recommended strongly, without any scientific basis, that these recommendations should go forward based on personal experience and beliefs, not science. Now, you would wonder, how would the Endocrine Society publish a set of guidelines? They're not standards of care at all, they're guidelines. How would they publish that without a consensus of the organization? They very subtly, it's kind of like something that gets published in the Federal Register. Didn't you read, sir, that if you wanted to respond to a federal law, that it was published in there and you had an opportunity to say something? We happened to catch a number of us in the endocrine field who were a bit dismayed at these guidelines in their iterations as they were being written, that these were not good guidelines or appropriately scientifically based guidelines, and we provided some input to the committee. None of which was used in the process of coming up with the conclusions that were published. So the Endocrine Society guidelines are essentially the opinions of 9 people. There were no contrary opinions on the panel. Missing was Dr. Paul McHugh. Missing was Dr. Kenneth Zucker, who Dr. Levine mentioned, who was really the pioneer, if you will, in the study of what was then called gender identity disorder, and then subsequently gender dysphoria. Why those people were excluded from the committee is only up to speculation. I have not personally spoken to the individuals on that committee. I know some of them personally. But the guidelines were published and this was within 2 or 3 years of Dr. Spack's opening his clinic, and he was one of those members of that committee. And that was when we began to see the exponential increase in the number of transgender treating clinics across the country. So to explain to you, where was this hidden? It was not that it didn't exist. As Dr. Levine said, it was a morbidity that was out there, but it had been amplified by communication and the internet, all the social websites. If you look at the incidence of transgenderism and the incidence of use of or availability of Twitter and Facebook and whatnot, the rise parallels that. Now, that's an association, not a cause, but it's interesting that you wonder where this comes from. How did this happen? And in the advent of these clinics showing up in across the country, now upwards of 65 of them, they tend to be based in academic centers because the academic centers are very sensitive to being up to speed with the social aspects of medicine. So the impetus is not, I would like to be optimistic and say it's not financially driven, but it is to become a sensitive person, somebody who recognizes the complexity of society and discrimination against individuals. It's almost an overreaction to be sure that you are the most up-to-date and the most appropriate and sensitive center. And to do that, you need to have a transgender clinic to provide care for the patients in your geographic region. There is an incentive that's sort of perverse. The U.S. News and World Report magazine or surveys every year of best hospitals has a pediatric endocrine section in it. And one of the questions in there that you get points for that increases your score is whether or not you have a transgender clinic and whether or not you've increased the number of patients from year to year. If you do have both of those things, you get extra points and your hospital goes up in a rating. So many academic centers are very interested, as Children's Healthcare of Atlanta Consortium is in Atlanta, they want to have a higher rating for their endocrine division, and therefore they quickly cobbled together a transgender clinic, which has been in operation in Atlanta for about 4 years now. So that's where this came from. You would say, how is this accepted by the general medical community? We've got the Endocrine Society writing these guidelines. That says that 20,000 ostensibly members support that. Take it a step out further, and the American Academy of Pediatrics, to which I belonged for a number of years, has 67,000 members, and they came up with a guideline written by one individual that was reviewed potentially by the executive board and a small committee. The best guesstimate of people who laid hands on that and edited those guidelines is maybe as many as 30 people in an organization of 67,000 members, none of whom, well, obviously 35 potential members, were able to review those records and give input. The rest was done behind closed curtain. So those guidelines are written, and they sound very impressive. Okay, the American Academy of Pediatrics recommends this. The Endocrine Society recommends this. The Pediatric Endocrine Society guidelines came out as sort of a parallel set. And those are quoted often, and you will hear them quoted when you hear folks on the other side of this affirmation issue, that they recommended that the mainstream medical practice is that these guidelines should be followed. These guidelines are written by activists in small committees who got into the power and made those guidelines published. Interestingly, in the Endocrine Society guidelines, they recommend the specific hormone manipulation from wrong sex hormones and talk about levels to be achieved in the serum by giving estrogen to biologic males and testosterone to biologic females. At the same time, the Endocrine Society has published a set of guidelines which they paired with the international endocrine community, saying that levels of testosterone above 100 in women should be avoided at all costs because of the side effects and the adverse outcomes in adult patients women who are asking to be treated with low-dose testosterone. One Endocrine Society guideline says testosterone above 100 should be avoided. The endocrine guidelines for transgender say get that level of testosterone in females up to 1,000. Now, same organization, disconnect across. The guidelines for testosterone and treatment in adult women are very specific and have wide scientific validity behind them. So from the endocrine standpoint, and I'm going to stick to the endocrine standpoint because Dr. Levine did such a great job of describing the mental health side of it. Why would we be concerned about puberty blockers as pediatric endocrinologists? Why would we be concerned about wrong sex hormones? We're not doing surgery. I can tell you my opinion of that, but I am not an expert in that field, and I would defer to a plastic surgeon who could give you more information. I certainly have talked with colleagues, as Dr. Levine has, about the problems with the surgical issues. But the medical issues in puberty is not a disease state. Puberty is a manifestation of human physiology to take a non-reproductive individual and change them into a reproductive adult, either male or female. Sex is binary. It's established at conception. It's recognized at birth, and it exists for the lifetime of that patient. People with disorders of sexual differentiation where their genitalia are looking abnormal or mixed at birth are not a third sex. They are either male or they are female. And that is the standard of endocrinology as it's written in science and proven. So puberty is there on purpose, and to treat it as a disease state or say the problems that happen during puberty, if you go through puberty, you're going to experience anguish. Well, everybody here in the room I'm looking at, I think, went through puberty, I'm assuming, and had anguish over things that happen to your body. Acne, in particular, is such a devastating disorder to a number of people who are acne prone. We would never in our life recommend stopping puberty to keep acne from happening. So this is, it's a different kind of a concept, but there is lots of pain and agony about changing your physical body from a prepubertal body to an adult. And so puberty has a purpose. It is often difficult. It has all the social aspects associated with it. In an endocrine practice, we see large numbers of kids who are suffering from delayed puberty. It's the social aspects of it primarily, but in some cases the hormonal aspects as well. So we treat those kids. We watch them to go along. We help them move through puberty. We support them emotionally, and we get them to recognize that puberty will happen eventually, and that we guide them through that and watch the outcome. It affects physical growth and stature in boys in particular. It's a very sensitive issue. So, we know that puberty has a purpose, and we know that hormones are necessary and appropriate. The biologically appropriate hormones guide you through that. We also know from disease states where the opposite sex hormones are overproduced because of pathologic conditions, that those things are harmful. An absence of estrogen in a female who has no ovaries at birth, the estrogen must be replaced at the critical time of age 10, 11, and 12 to begin that and maintain that through young adulthood in order for their skeletal calcium deposit to be able to be created and avoid osteoporosis and severe bone disease as an adult. We know that from that particular, and these are not transgendered individuals. These are not people with puberty blockers. These are people without females without estrogen. It is a devastation to their skeleton if they don't have estrogen. We aggressively treat to put it back in so that their bone health is appropriate. So we know from natural disease states that the appropriate sex hormones are very critical for the development of that individual. Testosterone specifically increases hemoglobin levels, increases physical strength at a time when the body needs to gain that strength to do what the male body was designed to do. Not what the male personality was supposed to do, but what the physical body was supposed to do. So those hormones are there on purpose. And to block those, we have no idea from puberty blockers in adolescence, in the adolescent age range, what the outcomes are. We do know in kids with precocious puberty, for which these puberty blocking drugs were developed, that we stop them, and within 18 months, the motor gets running again after the last dose, and they come back to essentially where they were before these drugs were introduced. So that information we do have. Yes, that is reversible, but we don't have any experience. No one has done a prospective controlled study to say if you block puberty and you get to 20, and if you don't block puberty and you get to 20 in the transgendered population, what's the difference? What's the health outcome? That study needs to be done in order for that drug to be approved by the FDA for use in the transgendered patient. And no such study is ongoing, and no such study has ever been done or published. That's the puberty blockers. So as Dr. Levine indicated, there are brain issues as well as physical body issues that are related to going through puberty. And it is a giant experiment to do this to children. And then as Dr. Money did back in the days, I have an idea, I have a theory, I have a goal, I really mean well for these patients, I'm compassionate for them, and I'm going to try something on them, and we're going to see where we are 20 years from now. And that's why children should not be experimented upon, because it is a giant experiment. There are laws passed in states where puberty blockers cannot be used to sterilize pediatric patients. And so, again, that's where the law has stepped in some states to keep that from happening. So that is the issue with puberty blockers. The wrong sex hormones, there's, again, disease states that the Endocrine Society gives guidelines to say testosterone levels in women that are elevated are toxic. The estrogen levels increased in males create stroke risk, hypercoagulable states. And therefore, we want to make sure that those disease states are eliminated with appropriate treatment so that the morbidities don't happen, okay? That's in the adult world. We do not know. We can see the physical changes in the transgendered child who's been given the wrong sex hormones, the physical changes, the things that become irreversible. And so we have experience to know that that is an issue. Fertility, clearly, in a puberty blocker that's stopped early, after a short time, fertility will come back. If you block the organizational development of the ovary and the testis in early adolescence, and then on top of that put in cross-sex hormones, you literally are guaranteeing, in the vast majority, sterility for life. The final step with surgical removal of those organs is absolutely proves you eliminate fertility altogether unless there's been cryopreservation of spermatozoa or oocytes before the whole process, which is a crazy expensive procedure that most of these disadvantaged families would never have access to. So we know that there are problems. There are disease states in adults. The big studies show that heart disease and stroke and cancers increase. The male breast tissue is highly vulnerable to exposure to estrogen, and breast cancer increases exponentially in adult males who are treated with estrogens. So this is something that we know. We haven't done the control studies, but when we don't have a control study, we rely on nature and other disease states to look for parallels of what happens. And this is why it's so important for us not to do something. If we want to do a scientific study, we must have a control group. It must be an ethical study. And this is what brings up the scary thing is there's one multi-center study of transgender children in the United States, NIH funded, which is coming close to its fifth and final year. It is not a study which has any controls in it. It's a study of reviewing what happens to these kids in the transgender clinic environment. When they go in there, what the outcomes are at 5 years. Not 10 years, not 20 years, not 30 years, which is what you need to know about, because from Dr. Levine's standpoint in his treating the transgendered adults, the morbidities, health morbidities and the psychiatric morbidities are large in scope at that time. The study from NIH is not directing these clinics to have a specific protocol. It's just saying whatever you do within your organization, and there are 4 centers in the U.S. that are collaborating for this, let us know the outcomes, how things look at the end of 5 years. And that study will be published probably within a year or so, maybe sooner. And that is the only study that's been done. It is not a good study because it doesn't have control groups. It's not a good study because it doesn't have a protocol that's uniform in all centers. So it is going to be a study from which will be cherry-picked some data. And that's, again, when you'll hear the trans affirmation advocates, they're going to cherry-pick information out of old data and ignore the big picture, as they often do, and publish that. And it's a sort of a self-affirmation publication situation where they'll pull something, write something from anecdotal experience and cherry-picking data from a study, publish that, and then a year or two later quote this study as the expert study that proved the point, quote that again, and requote and requote and requote. And if you look at the bibliography of the WPATH guidelines, it is full of anecdotes and recurrently reported studies. No valid science, because no valid science in children has yet been done. So the guidelines where they recommend these things have no scientific basis at this point in time, but they are the WPATH's idea of what would be the purposefully compassionate, appropriate thing to do for transgender children. Now, the mental health issue, I will tell you from my experience of having interviewed and discussed what goes on in these specific clinics that are not every clinic, and not cherry-pick clinics, just the ones where we happen to have an access, a discussion of what happens, is they are a conveyor belt very quickly. The clinic in the Children's Hospital of Orange County, director of the transgender clinic, Dr. Mark Daniel, very kindly answered questions that were proposed to him about what goes on in the clinic. And he specifically stated that in the absence of obvious severe mental disorders, delusion, schizophrenia, major depression, in the absence of those things, that is once they eliminate the patient and they clear them past that, there is no further psychological evaluation provided as a routine. And specifically, the families are completely left out of the evaluation of the family dynamics. Proudly stated that. Said we don't do that. We've got some folks on staff if we see that there's some problems, but it's not a routine. How in the world can that clinic process those kids through where they affirm socially, very quickly put them on puberty blockers, a year or two later put them on cross-sex hormones, and send them down where essentially almost every one of those children ends up affirming? It's a pathway that looks like a golden Valhalla, and the problem is that conveyor belt ends and there's a drop, and no one follows the people that dropped off the conveyor belt. We don't have experience in children yet to do that. So I'm just from the endocrine standpoint, I cannot, as a practicing physician, do harm to children. I cannot fathom that this study at NIH had an institutional review board that possibly looked at the stopping criteria for adverse outcomes. I do clinical research studies frequently. I'm involved in 4 or 5 at this point in time. The training I have to go through every 2 years for the protection of human subjects to understand exactly what needs to be part of a research protocol to protect the patient from harm is absolutely absent in what's being done in the one study at NIH. There's no way that an IRB that I have had contact with. It's an independent review board. It's independent of the organization, independent of the finance. It's a cross section of people in many disciplines, including economics and et cetera, et cetera. Those boards look at those protocols and design and approve the informed consent. Now, if in the informed consent there's a mention that your child is going to be sterile, that would be the stopping criteria right at the beginning for any ethical study that I have ever had a part in. An exception would be for chemotherapy for where you might damage the gonad in a developing child, but there's more significant mortality that's well known and well documented to untreated cancers where they have to do the irradiation or adversely affect the gonads. You'll hear a comparison, well, these kids are going to kill themselves. That's death. We're preventing a death of a child by going ahead and affirming medically and socially. And the answer, as Dr. Levine said, no, that there is no science to show that at all. That it's a threat that's hung over. In addition, online, these teenagers and families know that if they want to proceed with this process of getting into the transgender clinic, initially the Endocrine Society said you must have a letter from a mental health practitioner that says you have a risk of suicide. The way to get your letter is to tell your practitioner you want to kill yourself. That gets your ticket into the clinic. And you can Google it and find it on the internet. The teenagers have access to this. And it says, hey, this is how you get it. This is what you say. This is what you do. Now, is it surprising then when you take a survey, a convenience survey of transgender kids who want to answer the survey, and they say, have you ever thought that you wanted to take your life? You bet. Of course. That's how I got here in the first place. That's what I was told to do. It got me in the door right away, and I'm on my way to where I want to be. So the suicide threat is a manufactured one. It does exist, but it is promoted as a way to get into the system. And therefore, if you survey people in that system who are not all patients in the system, but those who wish to answer a survey, you're going to get a convenience sample that's biased, and you're going to come up with data that looks really impressive to show that if we do not allow medical transition and social transition in these kids, we are going to have dead children as a result of that. And no parent can think clearly if they're told that their child is going to take their life unless they move this direction. So that is the problem, and it's I deal with the patients that come into my office. I show them the compassion that they deserve. These are not happy children. These are not emotionally satisfied children. They are seeking something that I cannot give them as a medical practitioner without what I would say doing malpractice and causing harm. Thank you.
Very good. Thank you, Doctor. Chairwoman Delisio, do you have any initial questions?
I do. Thank you. Just a quick housekeeping question. Whitney, you mentioned about no recording, and I know PCN lights are on, but is this also PCN to the right?
I know that there was a one organization that was given prior permission to record, and that they were the ones that were set up. I was told ahead of time beforehand, but no one of the general public is allowed to. That is our house rules.
And who is recording, please?
The chair has discretion. If I'm notified ahead of time, Representative, there was a request ahead of time for the Family Institute to do a recording. It's also, it'll be on my Facebook page. It's being live streamed as well. There was a request that was made ahead of time that is at the discretion of the chair of the committee.
Thank you, Chairwoman. I
Welcome.
wasn't aware of that, and Thank you for the information. I just heard Whitney's thing, and then I noticed this gentleman. Dr. Van Meter, the guidelines that you referenced in the process, that in this case that you described that the Endocrine Society went through to produce some guidelines, is that vetting process, if you will, sounded a little light to me, but you had said that the guidelines in essence would then be boiled down to somebody's experience and beliefs as to how they would implement them, someone being practitioners. My notes are correct?
Yes, and that's actually freely discussed when you actually open the 2017 revision guidelines, particularly as I've done, and read the commentary. They'll say, we highly recommend this, even though there is no scientific study to indicate this is safe or effective, but we strongly believe this is the right thing to do.
So, sir, I just want to understand then that another practitioner would also be then practicing according to their experience and beliefs, to the degree that beliefs factor into medical science. So then neither party would be faulted, if you will?
Well, the problem is that there's not a dialogue, and that's the one thing that you mentioned up front, which I'm really saddened that we don't have the other individuals being able to be here because of extenuating circumstances, is that we have trouble finding dialogue. We ask for dialogue. I personally, as a member of the American Association of Clinical Endocrinologists and the Pediatric Scientific Committee, asked that we have a dialogue presentation on transgender health at the meeting in Houston about 3 or 4 years ago. The Pediatric Scientific Committee recommended that dialogue happen, and things like quiet, and the meeting brochure came out, and there was a transgender presentation by Dr. Rosenthal from San Francisco on just his affirmation.
Well,
We can't get our foot in the door, and I didn't mean to speak over you.
No.
I didn't just disrespect.
Well, you're here, so but I do. That was what was attractive to me in working with Rep. Schemmel on this, was that opportunity for dialogue. I think we all wish COVID-19 hadn't happened, to have provided that opportunity, and hopefully we can go forward somehow figuring out how that dialogue happens. Some of the caveats that you have mentioned. About 4 years ago, I happened to be diagnosed with breast cancer. Now, wake up one morning and all of a sudden your life's a little changed. Now, I assure you there was lots and lots and lots and lots of fine print in the paperwork that I had to execute in order to get treatment and have informed consent. And it was interesting, about 2 years ago, staff person who worked, unfortunately, in this building, had a diagnosis related to the chemotherapy from 10 years previously. It happens. And that diagnosis was very different than breast cancer, but it was a direct cause and result of the chemotherapy. And it suggested that I confer with my oncologist. And, was I aware of it? And interestingly enough, when I, said to the oncologist, holy crap, she said, I guarantee it was in the fine print. And quite frankly, would you have made another decision? And the answer was no. I was very fortunate to be able to withstand the protocol. And today I'm here, obviously. But some of the caveats that you were mentioning kind of reminded me of an insert in something you get from the pharmacy, and insert in a drug. If you ever look at those inserts, they warn against everything and anything and the kitchen sink. Now, whether the probability or the possibility of those events occurring vary. It varies on the individual. It varies on extenuating circumstances. It just varies on a ton of variables, and those inserts are there to both alert and advise, although if the print gets any smaller, I'm not sure how much alerting and advising we're doing well. So I can appreciate there are caveats with any medical procedure, with any medical course of treatment. There are. I'm not sure there's a practitioner out there that would say, I guarantee this. I guarantee the outcome. So I think when some of those caveats are mentioned, and particularly one in particular, it sounded like puberty blockers sterilize kids. That's what my note said. There are a few steps in there. I mean, is that so? If somebody is given a puberty blocker, they are sterile?
While they're on treatment, their gonadal function is shut down completely.
Well, if they're children, we're hoping they're not reproducing.
Right.
So if that is a temporary, limited event for something that wouldn't even be occurring, or certainly the majority of us hope don't occur before somebody is well prepared to have a family, is that what you were referring to? Is that just the fact that the child is on a puberty blocker would prevent them from reproducing, but that's neither the goal nor,
The goal is, and again, Dr. Levine stated it so eloquently, the adults who have, as looking backwards, said that for them, the changes of puberty were the most difficult that they experienced. And it was based on that recommendation that puberty be blocked. We don't know. We have no idea about what happens to an adolescent who has puberty blocked. We know that if it's a short term and nothing else is done, the likelihood of return of gonadal function is good. I mean, that, and in that way, it's not reverted. It is reversible, as if nothing happened. Pretty much. Okay, we know that in the experience of kids with precocious puberty, these are children who are girls and boys who are 5 or 6 when they start going into full-blown puberty. Socially, it's very difficult for them to handle. It shortens their growth potential significantly. So that is the impetus for why we would offer stopping that for a short period of time until.
And that is a practice, sir, if I understand correctly from what I've read, that you do within your own practice.
Right, and I'm actually involved in clinical research with the long-acting form of a puberty blocker with AbbVie Pharmaceuticals to look at its effectiveness. But its indication is specifically for the very, very tight criteria. And we're talking about 1 in 5,000, 1 in 10,000 kids who are treated with these medications. It's a very, very small niche market and outrageously expensive. And so, but it's covered by insurance in most cases. Certainly in the state of Georgia, Medicaid covers it for kids appropriately. So it allows us to actually pause puberty on purpose, but then to let it come back to its natural state. That's the only science we have on that. Okay, there's no one has done anything to look at whether or not when you get to the age of puberty, when the body is physically expecting to get ready, if you block puberty then and then let it go, how much do you recover? No, there is no study done, and that would need to be done for me to be able to recommend that. Puberty blockers are really okay because they are fully reversible. Let's just not even talk about going on the conveyor belt, because I'm going to assume you're not going to be on that conveyor. I would be optimistic that this is a phase where you needed to sort out your thoughts. And that's the guidelines and from the Endocrine Society and from WPATH and from PES and the AAP say the purpose of this is to allow the child to settle and get their thoughts together and see whether or not they actually are indeed satisfied with where they're going, or whether or not they want to go back and get back to where nature had intended them to go in the first place. So, but that's not what happens. But if that were the case, and they could show, we've studied this for 10 years, and we've got data that shows that recovery of gonadal function is, 85%, maybe 10% kind of iffy, and maybe there's a small fraction that don't come back. And we've got a control to show that that's the risk you take. That would be something that would make me look differently at recommending against puberty blockers. But there's no science, there's no study that's been done, and there's none that will be done likely. And we're sort of explosively going in a direction and using the John Money theory of let's see what happens. Let's get out there and see what happens. And the problem with that is that 20 years later you look back and say, what the hell was I thinking? I mean, wait a minute. Look what we've
But we
created.
can say that, sir, for any number of things. I remember when they used leeches and bloodletting, and even when I was born in the late 1950s, pregnancy was treated very different, just the very natural thing of delivery. And I'm not suggesting we use children for experiments at all, sir. I'm just suggesting that these types of things with this particular medical sector are not so much cyclical, but that's part of how we evolve.
Certainly.
So look forward to hearing more in the future.
Okay.
I consider this my first foray into this.
And I really appreciate your interest in the dialogue, and anything we can do and you can help us with to get dialogue going would be really appreciated. These kids need that. They really do.
Thank you, Mr. Chairman.
Thank you, Madam Chair. Doctor, in response to the last question, you were talking about no studies. I mean, in medical practice, do you normally experiment on human subjects without knowing the outcome? Is that a common, is that commonly how new procedures or new treatment protocols are, come about?
No, it isn't. And I'll give you an example of the use of human growth hormone in adults to fight aging, to sort of from the eternal youth, if you will, using actual human growth hormone, not mock-ups that don't really work. That is being done, without any control. It's just the lure of, hey, you want to stay young forever? Come to my anti-aging clinic. And these clinics our view of these clinics is that they're charlatans who are making a lot of money and experimenting on humans. And so in the medical community, we look askance at those things and say, I wouldn't go there. They exist. I don't know how they're regulated. Perhaps some lawsuits 10, 20, 30 years are going to come back at those folks that did this. But for right now, we cannot recommend that. That's not the standard of science. And so those things are roundly condemned by professional societies as a rule.
So if I hear you right, you're saying that gender affirmation using puberty blockers and cross-sex hormones, that's done without the normal scientific study and analysis. I think I'm hearing you say that. And you're saying that is unique to this, that you don't know of anything, at least within your medical experience, where we are treating large numbers of people with unanalyzed or properly analyzed science. Is that?
I'm not aware of any other circumstance.
Okay. What age do children normally go through puberty?
The average age for females is to start with breast development at age 10 and a half and to sort of completely mature into fertility by age 15 and a half to 16. In boys, the average age is 11 and a half for the beginning of puberty and completing that sort of by age 18.
So I presume in the context of gender clinics, at least as you're familiar with them, the use of puberty-blocking drugs is always pre-puberty. Is that? I mean, there's no reason to give it post-puberty?
No. It's actually they wait until puberty starts. Okay, and that makes sense. It's actually it's off label and off protocol. There's a clinic in Los Angeles where they suggested giving puberty blockers extra early so that puberty never even gets started. That's not the general recommendation, and certainly not the recommendation in the guidelines. They say wait until puberty starts, and at that point in time, as they move into true puberty, and you need to document they're there, not just a physical appearance, but laboratory studies and other things. And then it's at point in time that you offer that puberty blocker.
So in gender affirmation treatment, how long would the child then normally be on the puberty blocker?
Probably a year or two, because the push then is to be able to get the opposite sex hormones started in order to get the changes made that would normally happen in parallel to their peer group.
Okay.
So that the female who wishes to be a male would want to go and have increased muscle mass, hair growth, et cetera, that looks like the age-matched males that they wish to be, okay? And likewise, the same thing with the females.
So if I'm putting the pieces from your testimony together and that of Dr. Levine as well, some will say, well, the use of puberty blockers in gender affirmation treatment, it's number one is a pause to give the individual a longer period of time to kind of sort out their issue, what issues they believe that they may have. And then cross-sex hormones would be administered later if they want to proceed. Now, I'm hearing Dr. Levine say that actually what it does is sets them on a path where they start with the puberty blockers and go right into cross-sex hormones. So this decision, to start down this path begins with a child at age 10 or 11. Does that sound correct?
The medical treatment side begins at age 10 or 11. And it's interesting that the guidelines from the Endocrine Society specifically say cross-sex hormones at age 16, not before, and puberty blockers at the onset. That would give you the impression then in a female who starts puberty at 10 that there would be 6 years of puberty blocking. Again, much longer than is actually really done in the clinics.
Sure. And your work with puberty blockers and extended periods on puberty blockers are for children that are younger, precocious puberty. So that would not be this age cohort.
And rarely do they have 6 years of treatment. The onset of puberty in kids that's non-pathologic. There are circumstances that look like puberty in 3-year-olds and 2-year-olds, but it's from a pathologic production of a hormone from a tumor or a metabolic derangement, which can easily be treated not with puberty blockers, but just correcting that, taking the tumor out, or correcting the metabolic disorder by replacing other hormones that kind of put things back in normal working order. So true precocious puberty is really rare to be seen before age 5 or 6 in females and 7 or 8 in boys. And it's therefore you're limiting just by nature the window in which you treat to about 3 years, maybe the longest 4 years in cases of true precocious puberty that can be treated with those puberty blockers effectively.
But that still just pauses precocious puberty, so the child is going through puberty at a time when his or her peers are. So once again, putting the pieces together from Dr. Levine's testimony, we say that, well, puberty blockers are just being used as a pause to allow the child additional time to sort this out. And Dr. Levine testifies that, extended period of puberty blockers where a child is not going through puberty when his or her peers are results in other psychological issues, psychiatric problems. So is there pressure then, and maybe this is just a rhetorical question, to go right to the cross-sex hormone, after the 1 year, 1.5 years of puberty blockers?
Well, it's interesting. The iteration from 2009 of the endocrine guidelines and then the revision of them in 2017 specifically stated that age 16 still for cross-sex hormones, except when there are extenuating circumstances where the delay in puberty might cause some social problems, which is a wide open door to say, jump in, at the regular time of puberty, and what in truth is recommended by the people that run the clinics that are open enough to discuss it.
So cross-sex hormones, once those are begun, that is a lifelong regimen. Is that correct?
It can be stopped, but what happens is that if you are a female and biologic female and you take testosterone, your body changes physically in ways that it cannot be undone, the same way it would be during puberty. So my experience in meeting adult females who were trans males for a period of time and then came back and returned to their biologic sexual identity, their voices are down here and they have sort of square jaws and they have trouble feeling or looking like a female again because of what they did to their bodies with the cross-sex hormones. And so there are those changes that cannot be undone. Certainly we don't know about the fertility. There are anecdotal case reports of trans males stopping testosterone therapy and being induced to ovulate because they have their uterus and ovaries remain. They did not have surgical excision of the vagina, the cervix, the uterus, and the fallopian tubes in the ovaries. They technically can become pregnant and have become pregnant in a couple of celebrity cases where this has been reported of trans man delivers baby. But those are it clearly can happen. Fertility can be made to return with some significant machinations of medical treatment, but it is it's experimental again on that, and no one really knows.
Okay, so one of the things we commonly read is that these are reversible because we have to justify why we allow them to occur with children who once again don't have agency. They might express a desire to be the other sex. But they are children. We don't let children make any other decisions. So adults are actually making those decisions and administering the treatment. So these are decisions being made on behalf of someone else for someone else. And they're often justified by saying, well, that's okay because they are reversible later in life. If that individual, when they reach maturation, desires to, return to their biologic sex, these are reversible conditions. So what, in your professional opinion, what do we know about the reversibility of them?
We don't know. It's not been studied for us to know. We can only sort of look at sporadic cases that get reported and make assumptions.
Okay. Other questions? Representative Kiefer.
I'm just going to ask an obvious question that we're going back and forth and kind of parlaying off of what Representative Schemmel went on. Was we're adults making these decisions for children, and what happens when we get that child, and perhaps you or one of your colleagues participated in providing that medical service, and then we have a plastic surgeon involved, and this child is now an adult, 26 years old, and says, what happened? Why in the world would you ever allow me? That's a case for malpractice. I mean, and then how long do they get to go back to say, hey, this was, once they discover that, I didn't have the mental capacity to really make any of those decisions or agree to any of this, and what implications are there for all of us, quite frankly?
It's a scary prospect, and I think that will possibly be a catastrophic end to medical careers, to hospital healthcare systems, and then worst of all for the patients that were involved and the suffering that they have for their lifetime. I mean that's above all things. I mean the rest of that is gross inconvenience and makes a dent in society. But that one individual, that precious individual whose life was forever ruined, has been ruined, and it's been done intentionally.
Right, and again, I go back to the point. We're making these decisions. This is children.
Yep.
Once you're 18 and you're making these conscious decisions for yourself, that's a whole different, story. We're not talking about that. I'm talking about.
And as an endocrinologist,
children.
I can look at the data and say I would not recommend that anybody over age 18 do this without knowing fully what's going on. But under no circumstances should a child beneath the age of consent ever be subjected to this.
Right, and that informed consent is another piece that's really to it, because, I going into my pediatrician's office and I ask a lot of questions. I'm one of those researchers, so he dreads when I come in. But at the end of the day, I'll say to him, would you recommend your child get this shot, or you recommend this? And I trust, I have the relationship to trust my medical care provider, whoever that may be. So, that's another component here we may be breaking down.
Well, just the concept of assent of a minor in a clinical study. When we do clinical studies that involve children, which are the ones that I'm involved in, there is a very specific informed consent the parent signs, and it is that package insert that you are so familiar with the tiny print, and it's like a mortgage contract. Do I have to really read every page of this? And we literally sit the parents down and give them about 3 or 4 hours to digest every page of that, and they sign it. Then the child is given an assent form, which basically in very simple language says, for instance, in the case of the puberty blockers, you went into puberty too early. This is a medicine that is going to be a shot that you're going to get every 6 months. You're going to have blood tests drawn, and the purpose of this study is to help us know whether or not this medication is effective and safe. And you and your parents are going to discuss this. And if your opportunity here is to put your name down on the page to say that you understand what we're talking about. The parents are given the consent. The kid is given, do you understand? And I've not had a child, rule the roost and say, no, Mom, I don't want to do this. Usually they're kind of excited if they're old enough to understand for the age of 18. Yeah, I really want to. This is really cool. I'm part of a study, and that's the sort of the intrigue of getting an 11 or 12-year-old into something like that, is that they understand. I don't have the big picture from the adult world, but my parents, I'm trusting in them if they're going to consent to this, and I'm happy with it's going to screw up spring break because I have to have 2 visits in the middle of spring break, but I'm okay with that. Those are the kinds of decisions that kids will make, but they have to understand that, and they're given the opportunity to voice. Ask any child, do you want a blood test? And the answer is going to be no. But if you get the blood test to help this particular, and you're going to be getting treated anyway, this is just part of a study to see whether or not this new medication, which is a cousin of the one we know it works and is safe, is just as good as the one that's commercially available. So that's how it works.
And one more question for me. So in the surgical part, what other surgeries for gender-affirming surgeries do you know are being conducted on children?
What's called top surgery is basically bilateral mastectomies on female patients down as young as 13 in Los Angeles. And in the state of Oregon, a girl can have her breasts removed without permission of her parents or knowledge of her parents once she reaches the age of 14. So this removes an anatomically healthy organ that cannot be replaced. Somewhat sarcastically, the doctor in Los Angeles who has had these girls with age 13, 14, and 15 have mastectomies, has recommended them, said, well, if they decide later they want breasts, they can buy them. And said that in a public forum. Just kind of, hey, what a breast. You can buy one and have one put in. The answer is it's not a lactating organ. It doesn't function the way it's supposed to. Its sensitivities are not there. It's a sham and it doesn't work. And so that you're mutilating a body, taking a perfectly healthy organ off because of the opinion of a child who's unhappy at the time.
Representative Rapp.
Thank you, Chairman Schemmel, and thank you, sir. I have a couple questions that hopefully you can answer. I'm quite surprised that the blocking drugs are not, if I'm reading this correctly, they're not FDA authorized. And also, if you could answer for me, the World Professional Association for Transgender Health, and you also mentioned the NIH, the National Institute of Health. Does the World Professional Association for Transgender Health receive U.S. tax dollar?
I do not know. I honestly don't.
Well, and the NIH, are they supporting these clinics and these? What are these clinics getting receiving grant money from NIH?
The NIH gave them a $5 million grant to spread over the 4 centers, okay? And interestingly, their caveat for this is that all we're doing is an observational study of outcomes at these 4 individual centers and what they do within their own protocols. The study is not trying a protocol and unifying it and controlling it and seeing the parallel outcomes. It's an observation. And then that way they've kind of separated themselves out from being culpable from, because NIH isn't recommending this. We're just reviewing your data as you move forward in a prospective fashion.
Well, the NIH and the administration has been in the news a lot lately, and surely the NIH is aware that these blocking drugs are not FDA authorized. Is this typical in medical? You use the word experiments. So is this typical that the NIH would fund other programs that such as this?
Well, the way the NIH works is actually to design the research. So they would take a drug that maybe has another indication and in a very extremely controlled circumstance allow a small group of individuals, enough that you could get statistical significance out of the patient population. Let's say in kids maybe 15 or 20 individuals in a control group and 15 or 20 individuals matched socioeconomically, physically, mentally to be a parallel group. You obviously can't do a crossover blind study where you could, but I mean, injecting a sham medication and the real medication and seeing differences as they move forward is frowned on with kid studies particularly. But there is no non-treated group to compare to. And the NIH running those studies and actually designing those protocols, looking at the specific purpose of approving a drug would be a very different protocol than the one that's funding these 4 centers, okay? Because they're not recommending any drug specifically. They're just saying, whatever you're doing at your center, we want to see what the outcomes are like in the 4 centers that were sort of pioneering this.
So they'll be asked to submit a report
Yeah,
Basically.
that's it.
on their findings.
Yeah.
Thank you.
Good, thank you. Doctor, you said during your testimony, you said during your testimony that, at conferences where, academic research or other, medical information like that is shared, that you find that you and other individuals within the Endocrine Society or that represent an opposing point of view to the gender information are never invited to present. Is that, just for the rest of us who are not practitioners, is that unusual? And on other medical issues, especially ones that are fairly novel, where the opinion of experts has changed so radically in such a short period of time, is there typically offers or opportunities for people with contrary opinions, medical opinions, to testify or to present?
Not on this scale. I will tell you that having been practicing endocrinology for 40 years, knowing the politics, there's politics in medicine and politics in research in terms of getting funding. I remember specifically my mentor at Johns Hopkins was doing a study of adrenal disorders, which look like puberty but aren't. And was doing very much cutting-edge evaluation of outcomes on these patients. And he submitted his study to the Journal of Clinical Endocrinology and Metabolism, which is sort of the flagship journal of the Endocrine Society. It was held back while the editor of the Journal of Clinical Endocrinology, who was an pediatric endocrinologist from Cornell, waited and produced her study and published it instead of his study. And it was the same data, but it got her name recognized as the person who sort of published this first. So that kind of small stuff goes on and has gone on in the academic world of dog eat dog and, trying to get your CV and your worldwide acclaim for your research recognized. But nothing on the scale like this, where no voices. We finally, from our concerned side, had a letter to the editor accepted to critique the recommendation for puberty blockers in children to the Journal of Clinical Endocrinology and Metabolism. We wrote that letter. It took them about 15 months to approve it. It had very strict guidelines. We could only have so many references. There could only be 4 authors. But it did get published. It was the first time in a general mainstream medical journal that any contrary opinion was ever brought up. Almost immediately, the entire committee that wrote the guidelines came back with a rebuttal, which wasn't a very valid rebuttal, but it was their rebuttal, and that was published as a counter to our letter to the editor. But that's the landscape. We are literally suppressed, and in academia, there are people who are literally, and confide in me, they cannot come out and state their opinion for fear that their jobs are in jeopardy, that they will be removed from their academic position or they will never be published again.
So in your opinion, based on your experience, is the voice of people who are critics of this one treatment theory silenced?
Yes.
Okay, thank you. With that, any further questions? Oh, Representative Zimmerman.
Yeah, thanks. This is very interesting information, and appreciate your time and informing us. So just to continue the dialogue a little bit further, when there's puberty blockers, and at what point then does surgery generally happen, and is that outcome generally that an individual is going to be sterile? Is that correct?
The recommendations from the professional societies is that surgery not be done until the age of consent. There are some softening of the guidelines saying under circumstances where there's emotional duress that top surgery, so-called, in females could be done at a younger age, perhaps age 16. And those are sort of soft opinion pieces. They're not actually in the guidelines yet, but in practice, I don't think that many centers in the United States are doing surgical procedures on the bottom surgery, so-called, in kids before their 18th birthday. I think they're waiting for the age of consent for that. The outcomes of the surgeries, just to think of what you're doing anatomically to try to create. It's taking a breast off the chest is is done surgically for breast cancer. It's done for adolescent males who have incredible breast tissue development during their adolescence that doesn't resolve. It is a very delicate operation done to create a totally normal appearance of a chest wall without a breast. Is done by a plastic surgeon to retain the innervation and the blood supply to the nipple, the areola, so that it doesn't slough off and leave a scar. The surgical incisions are carefully made to be able to contour what looks like the natural curve of the nipple on the breast, and the patient has that tissue removed. That can be done, and it's done in kids, and it's known to be, when done well, have a reasonable outcome. What we have seen openly on the internet are the disaster cases where there is really incredible scarring and sort of disruption of the anterior chest wall that looks nothing like a normal chest in these patients. And if that could be that the surgeon that did that was not the appropriate surgeon and didn't use appropriate techniques, but it's still an outcome that can happen if not done perfectly. Mm-hmm. That's the top surgery. Again, you can't put that breast back. That's not reconstructible in any way. You can do a look-alike. You can create a breast and a nipple out of skin tissue and artfully put that back to appear to be a breast, but it's not a functioning breast. In terms of removing the genitalia in a male, taking off the penis and using the skin of the penis as a sort of an inside lining of a hole that's created in the area we call the perineum, which is above the rectum and below where the penis was. You create a channel in that tissue that is constantly compacted by the anatomy of the male pelvis, the bones that exist there, and you put in there the skin. It's skin tissue. It's not a mucous membrane. Mucous membranes have moisture and secretions to them that lubricate and that protect from infection. That cannot be recreated in the sense of a hormone secreting surface the way it would be for a vagina. So it's essentially a place to try to in which to have intercourse, which needs constant attention with dilation and it often malfunctions. And in the case of using intestinal tissue to create that lining, ruptures and causes infection and damages the urinary tract. The exit from the bladder is disrupted so that you have urinary tract infections and whatnot. Mm-hmm. So the surgical procedures are attempts to create nature that are, at this point in time, completely impossible to do. You can have it might look like it, but it doesn't work the way that tissue was. The fake created penises that are sewn on the perineum of biological females have no erectile function. They have no secretion. They have no innervation. They are essentially just a limp piece of tissue that hangs down and looks like a penis, but has no function of the penis. You can create a sac of tissue and put in two artificial implants that look like testicles so that hangs below that penis, but those testicles have no function and the penis has no function. So you are really doing a disservice to the patient even in insinuating that their sexual anatomy will have any physiologic function. It does not.
Mm-hmm. Wow. So just kind of a follow-up. Are there any studies kind of on the horizon at all on any of this?
Well, the problem in trying to do studies is the ethics of the study. So those of us who know from, again, the disease states where hormones are missing or are excessive in otherwise healthy humans, it would be considered unethical to do a study where you just, took a group of 20 kids and said, we'll see you in 20 years and let's see what happens. I mean, I can't envision that any institutional review board or committee for protection of human subjects would allow that to proceed.
Okay, thank you.
Very good. Thank you, Doctor. Appreciate your testimony.